Welcome to our actual very first episode of GrowthDx. I'm Ashley Kent, founder and CEO of Clearstart, and today I am joined by Dr. Edisa Shirley, who is the current Chief Growth Strategy Officer at ClinicMind, but has quite an expansive background as she has dipped her hand into quite a few different areas within behavioral health as a PE operator, clinician, and is now sitting in the growth officer seat in a technology platform. So we're super honored to have her join us here on GrowthDx and looking forward to our conversation today.
Thank you, Ashley. I really appreciate you. I appreciate you having me here as the first guest. I am absolutely honored. And yeah, I'm excited about this conversation.
Well, tell me a little bit more about your background. I kind of touched on it a little bit. You have a pretty unique background, and it's something that's incredibly valuable within the healthcare space. But, bring us all up to speed a little bit on, the journey of what has taken you to where you are today.
Yes, as you mentioned, I'm a Chief Growth Strategy Officer at ClinicMind. For anyone that is wondering what that is, we're a practice management platform. So EHR, revenue cycle, credentialing, AI tools, and we're serving behavioral health and chiropractic practices across the country. My path, as you mentioned, is a little bit unusual because I did start on a clinical side. I'm a licensed mental health therapist. And then I spent most of my career in operations, operating for PE groups, and also the M&A side of behavioral health. I was at Refresh Mental Health, which became part of Optum Behavioral Care. It was one of the largest acquisition in behavioral health space, and it did not happen. It wasn't that long ago. If we think about it, it was 6 years ago, I think something like that. I was leading post acquisition integration at national scale. Then I ran operations for PE-backed become behavioral partners, doing acquisitions and operational turnarounds across multiple states. So I've kind of lived like at every seat at the table. So I'm a clinician, operator, integrator. Now I'm on the technology side. And also, I have my own advisory firm where I do advisory work with investors. I do diligence, integrations. So I really get to see the whole behavioral health landscape from all different angles. And I kind of enjoy it. I enjoy having all those perspectives. So it really allows me to fully immerse myself into the field and truly understand what's happening, like from the top, where the money starts flowing to all the way to the bottom of patient outcomes.
That's incredibly interesting. And, it's not very often that you have basically you've expanded across the three different areas that, healthcare can cover from actually being a practicing clinician to going into the money side of scale and operations within a P-backed platform, and then all the way into technology, who is then selling into these as well. So you have this really cool 360 view into everything you've been doing, which is incredibly valuable. I want to take us back to your experience on the platform and operator side as you were going into these acquisitions and applying what you knew from the clinician side and taking a practice at scale. A lot of these practices, as you go from a handful of locations to 20, 50, 100 plus, whatever it may be. I'm curious from your perspective, what are those things that you found that maybe are specific to behavioral health that start to break? And then what are those kind of milestones are there certain milestones in size and scale that you see different break points within there that people just underestimate as you start to grow in scale and can tend to forget that maybe they should be thinking about that they're not?
Yeah, what's really interesting is that it's almost never the clinical side that breaks, right? The clinicians are really, for the most part, doing really, really good work. And where it really breaks is the administrative plumbing, I would say, underneath that. And it breaks quietly, which is really what makes it dangerous. So it's not that this is this one boom where you realize, oh my gosh, this is totally not going where it's supposed to go. First, credentialing, that usually breaks first. It's a silent killer of behavioral health growth in general. You hire a clinician, they're on a payroll, but they are not enrolled with the payers yet. So you're paying a salary with a zero revenue coming in at at 3 locations, it's a headache, right? At 30 locations across multiple states, with every payer having its own timeline, that backlog compounds, and suddenly you have months of revenue trapped in enrollment queues. So I would say, that is like a danger or flag number one. The second that usually breaks is RCM, billing. So the billing workflows that worked fine when he was just a founder and his wife, and they could look over everybody's shoulder, that starts leaking. So inconsistent documentation, front desk processes that were never really designed to scale but worked, right? Like, I don't know if you ever read a book, what got you here won't get you there. I always love to refer to that book, because it's really not that it was wrong what got you there, but it won't take you further. And I think this is very interesting for me to explain it to some of the founders, that you did a wonderful job with what you had to get it to here. But as you start scale, some of these processes, they're not designed to scale with you. They're not going to get you anywhere. I saw that firsthand at many of the acquisitions that I worked on, where, one of the one of the acquisitions I work on was my biggest, turnaround, was exactly that, where, I go in, clean the credentialing backlog, and then stop that billing leakage that happens sometimes because of credentialing, sometimes because of processes and workflow. So it's not a glamorous work, but it's usually where the margin kind of lives. So, people often ask me, like, well, when you go in, what do you do? Well, those are first thing you look at first. Yeah. And then, in the third part, I think it's worth mentioning is the integration work. When you're acquiring practices, every one of them arrives with its own unique challenges, different EHRs, different fee schedules, different culture. And most platforms budget for the deal, but they do not budget for the operational lift that comes after that. Like, even the first 90 day, and then what happens in a day 91, right? What happens like right after that? So, the way I put it usually to founders is, deals don't fail at signing. They fail months, or, month four, I would say usually month four of integration, where the infrastructure can't really absorb what you just bought.
100%. And that's such the value prop, right? That you're selling to clinicians. These are the parts that they don't want to manage anymore. And that's why
Hmm.
they're selling their practice in the first place. And that's where, as you're looking at the operations on the platform side, having a path and plan to scalability within there is so critical, but it can be the thing that is almost, like you said, it hits day 91. And people are like, well, we
Hmm.
didn't think about that. We didn't plan for it. And that's something that I've seen on my side as well too with multi-sites is, there's usually a breaking point where you can be scrappy up to a certain point and it's almost, it's as few as 10 practices, honestly. And there's all these decisions that maybe hadn't been made because they were trying to move quickly and they maybe started getting traction, with the clinics. And then, post 10, I mean, especially if you're getting into 20, if you do not have that repeatable playbook every single time when it comes to the operations, even marketing, even, all of those different things, it can break down really quickly because at the end of the day, like that's what they're selling,
Hmm.
for is for you to take that off and you to be that leader and that to guide them and what it may be. But it's not easy and even you can have the playbook of all playbooks and as you said every single practice has its own unique set of challenges and whether it's the people, whether it's the systems, whether it's processes and how do you start to go from where they are exactly like you said to where they need to be able to operate at scale. I'm curious what's the breaking point you've seen where being scrappy and nimble no longer works and you really need to have a more repeatable process as you start to acquire more clinics.
Uh, yeah, and I think something you mentioned, being scrappy. I think you're supposed to be scrappy. I don't want, like, scrappiness, and I know you're a founder yourself. Early stages of every business are supposed to be scrappy. And I think it's good to be scrappy. So I don't want to, like, sometimes like founders, feel like when you have those conversations that they did not do good enough or that wasn't good, it really is, it was good. You don't have this team. You don't have $5 million to invest in to build out this big C-level team. And now you're one person. You are billing manager, credentialing manager, you are front office person. Sometimes you're even a clinician. It really starts, I see it like between like $2-3 million of revenue to like $10 million of revenue, where I've seen practices where they are too big for the scrappiness, but not big enough to afford, let's say, a huge team behind them, right? Because it does take a team, and you have to get your business as a founder, as a clinician, often clinician, behavioral health. When I say clinician founder, I would say 98% of the time, the founders are psychiatrists. And, it's getting it, over that hunch of, okay, I need to really get, more resources in. And here, really, the key is the infrastructure, investing into the infrastructure uh, that will set you up for scaling. And that's what I think where some founders they find themselves in well, I can continue doing the way that I'm doing it because this has been actually really good versus, I am going to take what I have now and put these resources back into the business if I need to go from $5-6 million to $20 million, because that's what's going to take that.
Well, and especially when they've been given the mandate, right, of growth
Yes,
and obviously
correct.
leaning into the resources that, maybe the private equity group is able to provide to them. But I'm curious too from, it's a good transition into a question I have of the gap between the money side and the realities of the clinician side within there. And you being a clinician yourself, but also being on the private equity side of things, you know, where do you see that investors maybe they don't really understand specifically within behavioral health? That's a unique nuance to the behavioral health space that, is they should be more aware of that may be different than, primary care MSO or something of the like that would be very unique to behavioral health that you could warn against or make sure that they're aware of.
Yeah. I've lived that from probably just about every seat. So, at Refresh, which became a part of Optum Behavioral Care, you know, I was leading the post-acquisition integration. And now through my advisory work, I sit on the other side of the table that, I'm working on a pre-deal diligence for investors. So I really get to watch it exactly the same mistakes repeat from both directions. And this is kind of how I break it down. So before the transaction, understand what you're actually selling or buying, right? It is not just the revenue. It is not just the quality of your EBITDA, or it's not quality of the EBITDA, the payer mix, the clinician retention. Diligence will find everything that the founder seller has not fixed. So if I am on a seller side, right, my advice would be fix it before someone prices it against you, right? And also good rule of thumb is when you feel like you're ready to sell your practice, add plus 2 years or at least 18 months to get ready if you want the best, if you want to get the best value for your money. So that is like if you're a seller. If you're a buyer, that works in your advantage, basically, because
Always.
then it always does, right? Then during the transaction, the deal is a distraction machine, really. So, for the seller, their team really disappears into data rooms for months, and somebody has to really keep up with the businesses. So the organizations that really come through the best are the ones that deliberately protect their operators from the deal process. And what I've seen many, many times is during that process, business it decreases in revenue because you have, let's say, 5 partners, right? And each one of them is a clinician. And now they're working on this deal. You know how much revenue you're losing while they're digging through the diligence list. And then after, I would say this is the part that people underestimate the most, is the first 100 days set really the tone for everything. The clinicians at the practice, the truth is they don't really care about the cap table. They care about three things, right? Did my workflow change, or did my work change? Did my pay change? And did my autonomy change? And if the answer to those is nothing changed, except now you have better support, integration goes well. If they feel like investors, which sometimes they do that, they come in and the corporate, they call it corporate, lands on them on day one, and this is where you start bleeding that talent. And in behavioral health space specifically, clinicians equal to revenue loss the closest than in any other specialty, because patients leave with their providers. They do. I mean, if you think about it, if you have a therapist, you don't want to tell somebody else your full life story. I mean, basics, right? So that's something that it's very unique to behavioral health space, and that integration has to be planned very well to ensure that those specialty providers, of course, staff as well, are feeling comfortable, that those questions get answered, and that that they understand what their life is going to look like after corporate takes over.
And obviously, there's things you can put in the deal terms for, maintaining those providers there, but an unhappy provider in a, bad situation is, equals, not a great outcome also at the end of the day.
Mhm.
And I think that's incredibly interesting, and particularly on the private equity side. If you and a good call out, if they don't have experience on the behavioral health side, for them to, it's kind of the soft intangibles of within the deal itself, like you said, within those first 100 days. How are they making sure that the provider is feeling incredibly supported, and they're living up to the promises that they said in the deal process, and it's kind of the warm and fuzzies a little bit to keep them there, because, I mean, those truly are gonna be your revenue drivers within there, so I think it's incredibly helpful perspective within that.
Absolutely.
I'm curious, from that kinda leans a little bit into the culture of that, and, yeah, everyone has the private equity sort of, scary, it comes in, like you said, is it gonna be someone that's, like, really working with the practices, or is it gonna come in and just saying, "Hey, this is exactly how we do it," and, that corporate is coming in and stripping away the culture of that. How have you seen different organizations be really successful at, maintaining the culture, and what made those practices really special and successful in the first place, while, making sure that on the back end they have the resources and the standardization that they need to run effectively as a practice and grow ultimately, and finding that balance within there? What have you seen has worked well?
I think this is the question that I probably spent the most years of my career answering, because, even like a Refresh and Optum, I was involved with over 100 of integrations across, 300 plus centers in 30, I think 7 states. And the framework I landed on is simple to say and really hard to do: standardize the back office, protect the front of the house, right? So credentialing, billing, compliance, reporting, payroll, centralize those ruthlessly. I think there's a lot of value in it. No one's clinical identity lives in their billing workflow. No therapist has ever said, I love this practice because how we submit claims, how we scrub the denials. you know, that's where I think standardization is a pure win. But the clinical philosophy, community relationships, the local brand, this is where this is a way a practice shows up in its market. And that's the asset you really paid for. Touch it very, very slowly, or don't touch it at all. Where platforms get it wrong is sequencing. So they lead with a corporate playbook on day one, new name on the door, boom. You are not Susie's behavioral health. This is your new policy, new everything. And the acquired team immediately goes defensive, right? Because, now they feel like, okay, we've been doing it wrong. This has all been wrong. Where I've seen it work is when you flip the order. Your first moves take work off of their plate, right? you clear their credentialing backlog, you fix their denial, you make their life easier, measurably easier, before you ask them to change a single thing about patient facing. Because really, the thing is, standardization isn't really a systems challenge, it's a trust challenge. And once an acquired team believes that the platforms makes them better, they'll do anything for you. You can adapt anything. You can really do whatever. If they don't believe that, even the best change that you're trying to implement later, it's not going to work because they will push you back. That whole piece, that's a relationship piece. And many groups have, and I think we're getting better at it, and a lot of like investors and private equity groups are getting better at this, but investing in that integrations, culture, relationship, role, it's the key. It's, not everything's a playbook. Not everything should be a checklist where you go through it, because if you shake that up, you're just not going to recover. And then it's going to come back to me. I'm going to deal with the distress business. So, and I've seen it that as well. I've seen it where it's gone wrong and then they come back and they're like, well, we acquired this amazing, successful business and everything was going great. Revenue was going up and now it's declining. What's going on? It's usually that. It's usually people leaving, right?
Well, and the people within the organization, not just the clinicians, but front desk, office, anyone. I mean, they're the megaphone of what's
Hmm.
happening. I was working with a practice, and we were actually just talking about this past week, where you know they have that exact strategy where after they acquire, it's actually incredibly quiet. Where it's very subtle shifts. They're going right into back office first and getting the whole team bought in to this, that like life is actually better with this. And what actually ends up happening is then they start talking about, we're now working with XYZ,
Hmm.
and it's been
Yeah.
awesome, and they're able to be that advocate for you, that then turns into patient facing communications. And then you find that balance of, all right, now at what point do we start to introduce that on the patient side? And it all depends too, are you becoming are you going to be slapping on eventually like a consolidated branded house, or are you going to have a house of brands and they maintain that at some point, and that changes at what point you introduce the brands. But that's what, you've got the front desk already talking about it.
Hmm.
And then
Yeah.
what are those things you can start to introduce on the patient side that also makes their life a lot better? I'm working with a pediatric group right now, and within the first 30 days, they just started offering text messaging, the ability to text your provider,
Yeah.
which healthcare. Wow, how wild that we're introducing something as simple as this. But I mean, as a parent that can quickly now text the provider when their kid has an ear
Yeah.
infection, it's
Yes.
just immediately improvement. And so then they're starting to build that equity already by the experience versus just like, wow, we now have a beautiful branded waiting room. No, it's what are those things that are actually making someone's life better? And how are you being really thoughtful in that? And I love how you said, yes, in the back office, get their buy-in. And then on the patient and, other side of it as well. What are those little micro moments that you can start to slowly introduce this without it being like a train has hit them and we're
Yeah.
taking
No,
over?
100%. Yeah, no, 100%. And there's already bad, bad taste in the mouth for a lot of behavioral health. And I'll speak specifically for behavioral health, of the bigger companies acquiring, right? So it already does not sit well. Like, oh, it's a big corporate. Even if you're the most amazing organization, it doesn't sit well, right? So
Just
you have to be
personal, right?
cautious.
Like,
Very personal. Yeah. It's a relational business. And, I think there's ways of doing it, but just understanding how some of them may perceive some of this change, it goes a long way.
pivot a little bit into, you've been doing a lot of work within integrating behavioral healthcare into other specialties and what that has looked like. I'm curious where you've been seeing some of the most just interesting convergence within behavioral health, and where you've seen this be the most successful and maybe unsuccessful as well on that side too.
Yeah, this is honestly a topic that I'm really the most passionate about. Behavioral health is escaping that standalone clinic where we used to be. And when we talk about behavioral health, like even just 10 years ago, we were nowhere where we are today. So this is it's a new field. It's a new specialty, especially within the like an investment world. So really the convergence I'm seeing is happening in few unique directions. One that people really wouldn't expect, musculoskeletal and chiropractic care. Like at ClinicMind, for example, we serve both chiropractic and behavioral health practices, and we've actually presented a continuing education on integrating behavioral health, mental health into chiropractic setting. So think about it. So you have chronic pain and depression, anxiety, and physical function. It's deeply intertwined, right? Patients don't experience their health in silos, but we build a delivery system that pretends that they do. So it's interesting to see that how many patients that, let's say get chiropractic care and then get also behavioral health care at the same time, how their outcomes actually on Chiro's side improve. So this is a really unique one, and it's probably a newer kind of integrated care shift. Second one is long-term care, skilled nursing, assisted living. The psychiatric need in those settings, you can imagine, is enormous and dramatically underserved. I think the latest statistics were that only 16 or 17% of individuals in post-acute care receive any kind of behavioral health services. And I really think this is one of the biggest growth frontiers in behavioral health over the next several years. And then, the third one, I think that one is more talked about, it's primary care, right? Which is, most established convergence, but still has a long way to go, especially on the execution part. And and I think what's driving all of this is both clinical and economics. So clinically, comorbidity is the norm. It's not an exception. Economically, as value-based arrangements mature, whole person outcomes are really what's starting to get more rewarded. And you cannot deliver that whole person outcomes. Like, for example, like in a chiropractic care, they do believe that a whole person approach, which your emotional well-being is a part of that. So you can't deliver those outcomes with behavioral health sitting in a separate building or in a separate system, separate insurance, all of that. If it's all, delivered within even the same company, it becomes more, it provides better access to care, and not just better access, but better, care overall, and removes that barrier, to integrated care for our patients.
What are the models that you've seen work best so that people can continue to do what they do really well? Is it, partnering with someone who is able to build out that service lines? Is it building it in-house? What have you seen has been the most successful to actually build out these lines that are successful and, but also feel integrated to the full service offering?
I mean, I think the easiest step, which is would be phase one, if you're not able to, let's say, bring it in house, is to partner, right? Partnership is probably the easiest, least risky approach if you're just trying to provide your patients a better care. Where it's the most successful, if it's under the same roof, right? Doesn't need to be necessarily on the same roof, but if it's the same company, where you are basically building out the separate service line under your, MSO, for example, if you have an MSO, building that service line, because that provides easier way of, care coordination. If you're using the same EHR, right? It's easier, right? So now the provider on each service line can actually connect and collaborate better, like because they have visibility to the same, let's say documentation or treatment plans. But if you're not able to, for any reason, because sometimes it does require capital, if you're opening a whole new service line, even just partnering with someone in a community where you're like, for example, if you're a chiropractor and they provide behavioral health services, it might be as simple as, some kind of agreement where, for referrals, right? Hey, we'll send you all these referrals and let's collaborate on them. It can be simple as that, but it's not as effective unless you have a full control over just even referral process and ensuring that referrals that are sent to the other service line actually get followed up on and that they're acting on it and collaborating with that position.
Yeah, because I think so much of what you've talked about has just been incredibly practical and super applicable to, on both sides, on the money side, but then also on the operator side, as someone's considering, potentially partnering with someone and what should they be looking for. And so I'm curious, from the perspective of, the amount of deals you've been a part of, if you had a behavioral health platform today and, you were told you needed to double it over the next 3 years, what would be the first 2 or 3 things you'd wanna understand before building that plan?
So as I've mentioned even like earlier on a call, I think I would want to understand, I would want to see credentialing. I would want to see RCM practices or billing practices and understand people, structure of people. And if I once I understand those three pieces, then building out a growth plan based on where we are, what resources we have available to us, what resources we need in order to deliver to that growth plan. But really, would need to understand those three levers first before really digging into anything else. Some things could be an easy fix, right? So let's say if I have a platform and it's struggling, it's leaking money, or it's hemorrhaging money on a billing side, I need to understand why before I can make any kind of plan for the future. Are we even credential? Are we billing correct code? Are we compliant, right? Like we haven't even touched on compliance. I know we haven't touched on AI, but we haven't touched on compliance because that will shut you down. And if
Mhm.
you are not compliantly billing, or let's say you're overcoding, right? That's a big issue. I mean, I think across healthcare, then are you growing in a wrong direction? Are you heading the wrong way? Because as you get bigger, the issues that are small become big issues. So I think I would make sure touch those three: credentialing, billing, and people. Who do I have? Who my leaders are, who my providers are. Am I set for that? And then also, do I need to hire? And are the right people in the right places for us to be set for this growth? So I would go there.
Well, super practical both for, anyone that's under diligence and what they should be looking at, as they're looking at that, but then also a founder looking to sell eventually, like you said, getting ready in that 1 to 2 years. Super, super practical there. So, finish us off with, something I'm gonna be asking everyone on GrowthDx. And so it's the magic wand question, which I think is such a loaded question when it comes to healthcare because there's so much that we would love to
Yes.
fix. And, but if you had just one magic wand and you could fix one thing in healthcare, you had no budget constraints, no regulatory constraints, no politics. What are you fixing?
Access to care. And I know this sounds a lot of people use the words access to care, but truly don't understand what it means. Access to care means that every individual that needs care, if that is preventative or, regular psychiatric or regular, any kind of healthcare care, that can get it. And within appropriate time, within appropriate time frame, and not having to go through multiple insurance hoops to get there, because that hurts a lot. So if that could do one thing, it would be that if you need psychiatric care, if you need a therapist, you have access to them and you don't have to worry about if your insurance covers 90837, blah, blah, blah. That would be it.
I love that. Great answer. That's the dream, right? And there's lots of
Yeah.
awesome partners that are out there making things more accessible. And it's a slog every day,
Yes.
but I think that is incredible. So, well, thank you so much for joining us today. You truly have such a wealth of knowledge that is, like I said, just incredibly practical and applicable for people to be able to take away from this. So, thank you for being our inaugural guest and here on
Thank
Growth
you.
DX. And maybe we'll find some time for a follow up discussion for a part two because there's a lot we didn't get to. So,
Yes, thank you, Ashley. Thank you. It was such an honor. Thank you for having me. And absolutely, part two coming up.
Dr.